Hello, everyone, and welcome to Med-Surg Mini number 1, where we'll talk about pain management. First, to talk about pain, we need to understand the pain experience. Pain can be felt physically or emotionally. It can be chronic or acute. It is often impacted by a wide variety of factors, including biopsychosocial factors, genetics, your age. We find that younger individuals experience acute pain more often, whereas older individuals may experience chronic pain more often. It is impacted by gender, so we know that women tend to experience more pain disorders in more pain types than males. However, males have a harder time treating their pain. Culture can also impact the treatment of pain as well as the experience of pain. Health conditions, life experiences, and an individual's pain threshold and tolerance for pain also impact the pain experience. Pain is the most common reason why someone seeks healthcare, and the key to treating pain is finding and treating the source. If we're not able to do that, then we focus on symptom management. There's a couple of different theories as to how and why we feel pain, with two of them being the peripheral nervous system centric V and the gate control theory. So the peripheral nervous system central V basically states that as tissue experiences trauma or pain, it sends a message to the central nervous system, which then is triggered and says, hey, feel pain. It's directly back and forth, and the main criticism for this is that there's no regulation of perception. It's just in correlation to the degree of trauma equals the degree of pain. More accepted is the gate control theory, which states that the perception of pain is controlled by the spinal cord. And the spinal cord either sends a pain signal to the brain to feel that pain, or it attenuates the signal, causing us not to feel the pain. And attenuate means to decrease or inhibit the signal so that no pain is felt. As I mentioned, there's two different types of pain in the pain experience, acute and chronic pain. Acute pain has sudden onset and short duration. Typically, it'll last hours to weeks, and it lessens as tissue heals. It's often due to tissue damage, and it can promote adaptive behaviors. So for example, if you touch a hot pan, it's going to cause pain, which then causes you to avoid touching that hot pan and saving your skin integrity. So avoidance of pain and damaging causing events is something that acute pain allows. Acute pain also responds well to pain treatment modalities when compared to chronic pain. So chronic pain is often gradual in onset and has a long duration, typically 3 to 6 months or longer. It is often very disruptive to someone's lifestyle. The experience can be inconsistent and unpredictable. There's not always an obvious cause or tissue damage that lends to why the individual's feeling pain, and chronic pain treatment is a burden to healthcare treatment. There's two different other types of pain categories that we can look at. So nociceptive pain is stimulation of the peripheral nervous system through tissue injury. This injury often occurs in the bones, the joints, our muscles, our organs, and our skin. So for example, cutaneous pain originates in superficial tissue, and it typically expresses as tender, sharp, or itchy pain. Somatic pain originates in the joints, bones, and muscles, and it often is a dull, cramping, crushing, stabbing, sore, or spasmodic pain. Visceral pain originates in organs, and it can be crampy, achy, dull, pressure-filled, or stabbing. Referred pain is pain that originates in one part of the body, but is felt elsewhere, and I have a picture of that for the next slide. Neuropathic pain, however, is pain that originates with the central or peripheral nervous system. Because of this, we have the inability to localize or determine the direct origin of pain. This pain is generally more chronic, and it results in things like numbness, tingling, shooting pains, burning pains, pins and needles, shock, and stabbing pains. And here's the picture of the referred pain regions. So for example, the gallbladder and the liver, that purple color. It's technically located just right underneath the individual's right breast. However, you may feel that pain in the upper neck. Another example is you may feel lung pain in the upper neck. You may feel heart pain anywhere down the left arm as well as on the back. So this is what that referred pain looks like, and it's important to kind of know so that when we're assessing pain, we can determine if the pain is being caused at that region for a certain reason, or if it's indicating damage to an organ or something in another site. So how do we process pain? Pain is processed through nerve transmission. So our nerves are composed of nerve fibers, and these nerve fibers are surrounded by connective tissue. This connective tissue goes from the origin in the body to the spinal cord, where the dorsal root ganglion, or the DRG, allows that transmission to go from the nerve to the spinal cord. The DRG is often covered with myelin, or a type of connective tissue, and depending on how thick that myelin is, as well as the size of the DRG, determines the pain response that an individual feels. In between the connection of nerves, we also have neurotransmitters, which can be increased or decreased and impact the pain responses that are transmitted. So here is a picture to the right of all the different regions of the spine and the parts of the body that DRG connects to. So for example, your arms and your neck are part of the cervical region of the spine. That's where they integrate. The thoracic area covers most of the trunk. The lumbar area covers the lower limbs, and the sacral area impacts the bottom of the feet as well as the genital regions. So how does the pain processing start and continue? So first, an injury occurs. When injury occurs, it damages cells, and those damaged cells release histamine, bradykinin, and prostaglandins. These three chemicals cause an inflammatory response. As that inflammatory response occurs, immune cells start saying, hey, whoa, we have something going on here. So they start releasing pain-enhancing chemicals like your cytokines and your growth factors. As these cytokines and growth factors grow, our sensitivity and pain response occurs. We also have a category of pain called dysfunctional pain, and this is pain that doesn't typically follow our expected pain response. So for example, allodynia. This is a painful response to stimuli that doesn't usually cause pain. So for example, lifting my arm may not cause any pain if there's no trauma or damage. However, someone with maybe fibromyalgia may have pain when they lift that arm, even though there's no damage, because they're experiencing a painful response to stimuli that shouldn't be causing pain. We also have hyperallergesic pain, and this is an exaggerated response to pain stimuli. And then lastly, we have plasticity, which is the reorganization of pain nerve synapses that change our perception of pain. And we see this plasticity happening more often with chronic pain than acute pain. So how do we assess our pain? We can do a focused pain assessment, and there's also pain scales that can help guide our evaluation of pain. So the scales that are most commonly used are the FACES scale, the numeric scale, which is on a scale of 1 to 10, how severe is your pain, the verbal scale, and the visual scale. And I have some pictures of that on the next slide. When we do our focused pain assessment, we want to look at a lot of different qualities. We're looking at the onset of pain. When did this pain start? We're looking at the location. Where is the pain most painful, and does it radiate? Do you feel that pain in other regions of the body? What's the duration of the pain? How long has this pain been going on? And when, if it's an intermittent pain that kind of comes and goes, how long do you usually have it before it goes away? Do you know the cause of pain? Do you know any aggravating factors? So for example, does moving the area where you're feeling pain cause more pain? Do you have any relieving factors? Does using a hot compress or an ice pack make that pain feel less? What is the time of onset? Does it typically follow a pattern where you experience that pain more so in the morning versus at night? Or maybe you feel it more often after engaging in exercise. So we would assess that. Then we want to assess the severity of the pain and the quality of the pain. So the quality of the pain is the type of pain felt. So is it sharp? Is it stabbing? Is it dull? Is it achy? Is it pins and needles? All of those different types of pain that may be felt are included in that focused pain assessment. And here's an example of the different pain scales. So you can see on the left-hand side, the simple descriptive pain intensity scale is just stating no pain, mild pain, moderate, severe, very severe, and worst pain possible. Similarly, we have the 0 to 10 numeric pain intensity scale, where no pain is 0, moderate pain is around 4 to 6, and the worst pain possible is about 9 to 10. And then you have the visual analog scale. As I mentioned, we most commonly, especially in the pediatric population, will see the Wong-Baker-Faces pain rating scale. And this is where they actually have pictures of different faces, and it could be smiley faces like this, or it could be pictures of actual people depicting different levels of pain. And they have to point to the face that best describes the pain that they're feeling. So how do we manage pain? First and foremost, we need to assess the pain and take it very seriously. We need to determine if it's acute or chronic. We're going to complete our focused pain assessment and any pain scales as necessary. We want to assess how it impacts the patient's life and symptoms, and we want to know their pain expectations. What is their goal for treatment? As far as treatment goes, we'll talk about some pharmacological factors, such as assessing for appropriate route of pain med administration. We can give pain medications orally, IV, through injection, as well as topically. We need to assess if it should be PRN, which means as needed, or scheduled. We want, we want to determine the type of pain, origin, and pain experience. We want to educate the individual on side effects, adverse events, and overdose treatments, as well as be able to monitor those. And we want to determine if there's any placebo effects going on. Non-pharmacologically, we'll talk about some interventions as well, but assessing the environment and making sure that the pain treatment is in an environment that's going to enhance pain treatment is going to be very important. So pharmacologically, how do we manage pain? You can see here on the right, I have a diagram that talks about the different potency of NSAIDs and opioids. If you watch the pharmacology minis, you'll see that there's a couple of mini lectures on NSAIDs and opioids if you're interested in learning more about these different medications. But overall, for pain management, we'll typically use a non-opioid analgesic like Tylenol, ibuprofen, etc. You can see that these are less potent medications, and typically they will cover a lot of pain management. And so we start with that because it's least restrictive and potent. We can use opioid analgesics such as Norco and Percocet. We can use corticosteroids, which reduces the inflammatory response that can lead to the feelings of pain. Examples of this would be prednisone and hydrocortisone. We can use local anesthetics like lidocaine and EMLA. We can use topical rubefacins like Bengay and Icy Hot, and that rubs on the skin and it kind of starts off with a really warming sensation, and then it can go to a cooling sensation. We can use antidepressants as adjuvant therapy, especially our tricyclic antidepressants, and tricyclic antidepressants usually end in amine. We can use adrenergic agonists like cataprest, glutamate agonists like ketamine, GABA agonists like baclofen, which is very commonly used for spasms, muscle spasms, or we can use ion channel blockers like anticonvulsant. Neurontin is really helpful with neurologic pain. Some of our non-pharmacologic pain management strategies include different things like looking at if the individual wants Western, which is conventional medicine, or Eastern, which is complementary medicine. In healthcare, a lot of times in the US, we focus more on conventional medicine, which is the use of different medications to manage pain. Eastern or complementary medicine uses a lot of different forms of non-pharmacologic therapy to help ease pain, and we'll talk about a little bit of that. A lot of times we'll call Eastern medicine, complementary, or alternative as well. Our nursing considerations whenever using any non-pharmacological pain management is to make sure that we are assessing for any interactions with medications that the patient may be on, especially if they're using herbal or aromatherapy. We also want to enhance our education to make sure that we're giving them work, and we want to make sure that whatever complementary medicine we're using is still rooted in evidence-based practice. So some examples of complementary medicine that we can use is creating an aesthetic environment for that individual. If they are in the hospital, we want to make sure that their linens are comfortable, clean, and smooth. We can use different colors of walls to enhance a lower pain response. So research has shown that having green, yellow, or blue walls in a cool environment tends to be more relaxing and can reduce the experience of pain. We can use things like positioning every 2 hours to help with pain. We can recommend things like hypnosis, range of motion activities, aromatherapies, different relaxation techniques like distraction using guided imagery or music therapy. We can use prayer and meditation, deep breathing exercises, progressive relaxation, and we can use heat and cold application. With heat and cold application, depending on the patient's size and their experience of pain and the region of which they're feeling pain, we recommend hot and cold application for 10 to 30 minutes at a time. This application can also be wet or dry. To talk more about complementary medicine, the purpose of complementary medicine is to focus on promoting wellness, reducing side effects, preventing illness, and strengthening this immune system while enhancing someone's quality of life. It aims to modify, restore, and renew health and focuses on the patient holistically. It is also based on different energy paradigms. And this means that health is balance and healing is mind, body, and spirit, not just body. The different classifications of complementary medicine includes whole or alternative medicine systems, like Ayurvedic medicine, which originates in India, and this includes herbal care, yoga, massage, and diet-based changes. Traditional Chinese medicine includes a lot of herbal medications. Naturopathy integrates acupuncture, hydrotherapy, manipulative therapy, homeotherapy, and botanicals. And then we also have Native American medicine, which includes shamanism, ceremonial chants, dances, and singing, and herbal tinctures, salves, and tears. Different types of mind-body therapies that we can recommend are things like meditation, prayer, yoga, guided imagery, Tai Chi, and zero balancing. Manipulative or body-based therapy includes massage, chiropractic medicine, osteopathic medicine, reflexology. And then energy healing therapy includes therapeutic touch, Reiki, and Qigong. And then dietary supplements, botanicals, and herbal therapies can also be used. And as I mentioned earlier, if we're using dietary supplements, botanicals, and herbal therapy, we want to make sure we do a thorough evaluation of the patient's medication list to make sure that there's no interactions. Other things that we can do to manage pain include invasive devices. So there's the transcutaneous electrical nerve stimulation, also commonly called a TENS unit. This is a device that has electrodes that are placed on the skin, and it sends electric pulses to that skin to vibrate it, and it induces a tingling and heating sensation. The purpose of this is to interfere with pain transmission as well as to stimulate non-pain receptors. It's often used to treat post-op pain, osteoarthritis, and chronic pain. The other invasive device we can use is a deep brain stimulation device. And this is surgically placed device in the brain that sends impulses to the brain to reduce the pain response. It includes 3 parts: the implanted pulse generator, which you connect to lead, and an extension. This is very commonly used in the treatment of Parkinson's and Parkinson's tremors. This is also a pain management guideline that came out by the World Health Organization to kind of guide providers on the different steps to providing pain relief. So for example, if someone is experiencing mild pain, we should be using simple analgesics like Tylenol, NSAIDs, COX-2 inhibitors, with or without other medications. A lot of times with mild pain and all these pain levels, we're also going to combine it with some non-pharmacological pain managements. If they have moderate pain, we would recommend a weak opioid treatment. And if they have severe pain, we can use a stronger opioid treatment. Considerations for the experience of pain across the age span includes that older adults are going to experience more chronic pain, and they may experience an increase in chronic pain as they get older. This can lead to things like polypharmacy, so we want to make sure that we're assessing the appropriate use of medications. And they also can have different pain experiences. So for example, if someone's having severe chronic pain, instead of feeling it as a pain response, it may come across as fatigue or depression. So we want to be aware of different ways that people can feel pain in the older adult population. We do know that in the elderly, we experience an inflammatory response more commonly. They often have more dysfunctional liver and kidney activity, which is going to impact the excretion of pain medications. So we have to be aware of how their body's metabolizing these medications and use that to drive an appropriate dose so we don't cause any toxicity. We want to be aware to watch for more side effects also because of that factor. And we want to assess how the pain impacts their socialization and lifestyle. Children tend to experience more acute pain. As I mentioned earlier, we're going to want to use pain scales specific to that child's developmental age, like the FACES scale. And a lot of times when children experience pain, it's due to damage to tissue through broken bones, falls, scrapes, cuts, things like that. In addition, when an individual has a cognitive impairment, they may be unable to comprehend the pain and assessment scale, as well as the education on how to manage it. So we would want to make sure that we're using an appropriate scale for them as well. They may also have some comorbidities that enhance the experience of pain, and they may respond to pain with engaging in behavioral issues. And that is the conclusion of our first Med-Surg mini on pain management.